Good evening, everyone, and welcome to our Acute Sporting Knee Injuries webinar. My name is Katrina Pilbeam, the Workforce Development Lead at Western Victorian Primary Health Network, and I'll be your facilitator for this evening. I'm also joined by Jade and Helene, if she's in the room, from our Workforce Development team. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. We recognise their diversity, resilience, and the ongoing place that First Nations people hold in our communities. We pay our respects to the elders, both past, present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations people and organisations. A little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHUN YouTube Learn channel. We'll put the link into the chat to access the recordings. Please see our upcoming events on the screen. You can register for our events via the website. We'll put a link into the chat for our website. We're excited to announce this year that our annual primary care conference is in Ballarat. The date has been set for 10th and 11th of October at the Stunning Good Shed. So we'd love to see as many of you in attendance. Please note the Western Victorian PHN Health Pathways page there with the acute sporting knee injuries pages. You'll also on the slide some of the related pathways. A certificate of attendance will be emailed to participants. Please take a moment to put your full name into the chat if it's not displayed correctly. This will ensure we can issue you the certificate with attendance. Please keep yourself on mute unless you would like to ask a question. We encourage you to interact and have discussions at the end. If you would not like to come off mute, you can type your questions into the chat and we'll answer them at the end of the presentation. Your feedback is important to us, so we rely on you completing the evaluation survey. It helps us to craft our calendar of education throughout the year, and we really recommend that you fill that in for us. Tonight's presenters are Nick Maister. I hope I've got that right, Nick, sorry.
Yeah,
and
Maister, yeah.
Maister and Todd Mason. So I'd like to hand over to Nick first, I think it is. Thank you.
Mm-hmm. All right.
Perfect.
Come up right. Yeah, great. Yeah, so hi everyone. Thanks for having Todd and I come and talk and present. So hopefully we can try and target it and make it useful and practical and hopefully cut out too much of the boring sort of technical orthopedic stuff and try and make it useful and practical at a day-to-day level. So if there's any times where there's things you think would be useful to tease out further and you want to jump in at that time, definitely do, because I think Todd and I have both left it pretty open and broad to give that opportunity, because I think that's often the most useful part of these type of talks. So yeah, Todd and I are both orthopedic surgeons through Geelong Orthopaedic, so both based in Geelong, and we are going to talk about the acute and urgent sport knee injuries. So the objectives for this talk are to refresh on the different types of acute knee injuries, particularly the ones that would likely come through a primary care setting in a GP clinic. So the common ones being meniscal injuries, ligamentous injuries, fractures, patellofemoral joint injuries, and tendon tears and ruptures, and then we'll sort of broaden out on each of these. So we'll look at the principles of treatment, particularly early principles of how these should be managed first up, and which of these things, try and get a bit of an algorithm for which of these things are going to be best referred really urgently to us, and something you may even call us or text us about, versus the things that are more a non-urgent referral to us, or even sometimes starting with say physiotherapy rather than a direct referral to an orthopedic surgeon. So I'm going to start by talking about meniscal injuries, which, as we know, are very, very common. I think pretty much anyone that lives long enough will have some sort of meniscal injury. But that's sometimes the tricky part about meniscal injuries is teasing out which ones are significant and which ones aren't, and differentiating the sort of acute meniscal injury that can be something reasonably urgent that needs dealing with surgically, versus the chronic meniscal sort of injuries, or even sometimes the more incidental kind of injuries that are just seen on imaging done for other reasons, or just as part of workup for generalized knee pain. So when people have meniscal tears, they can present in all sorts of different ways as far as their symptoms. Commonly, they'll have no symptoms. I think if you went an MRI every one of his knees over the age of, say, 30 or 40, there'd be quite a significant percentage of people that would have some form of asymptomatic meniscal tear. But it's the ones that are symptomatic that we're sort of more going to be, I guess, looking at and dealing with. So there's certain ones that can cause immediate issues, and those immediate issues are things like pain or locking or catching of the knee. And then there's certain injuries that can cause long-term harm to the knee, and these are ones that where the sort of shock absorption properties of the meniscus is taken away. So if you've got a tear that defunctions the sort of the hoop stress, which is what disperses the force through the knee, so going from the cartilage of the femur to the cartilage of the tibia, the meniscus increases that surface area, and anything that takes away that sort of hoop stress, so that holding the meniscus in that position, such as a tear that goes right through the meniscus, so a radial tear, or like a meniscal root tear that's pictured here, where the meniscus can extrude out to the side. It functions as if there's no meniscus, which over either years or sometimes years, but more likely sort of a decade or so, certainly can speed up the rate of degenerative tear of the knee. So there's sometimes we'd advocate for operating on meniscal tears as far as a preventative thing for arthritis. And the other time is commonly if someone's got a symptomatic meniscal tear, either with pain or locking. And I think we got a lot of good evidence from probably say 30 to 40 years ago, where the treatment of meniscal tears was to literally remove the whole or nearly all of the meniscus. And people would get quite good symptomatic relief often early on, because that pesky bit of meniscus wasn't flapping around and catching in their knee. But we've found that all of the vast majority of those patients go on to develop quite severe osteoarthritis of that compartment. So the treatment has changed a lot over the last few decades to more, if you are debriding a meniscal tear, taking the minimum that you need to stop any of the mechanical type symptoms. And often, and there's been a much bigger shift towards trying to repair the meniscus where it's able to be repaired. So particularly tears like the bottom left there, where you've got a bucket handle tear, which is a big longitudinal tear that has allowed the medial part of the meniscus to displace, and commonly that will displace into the notch of the knee and cause either pain or locking symptoms. And as you can imagine, losing that big part of meniscus, you've got a less functioning meniscus. So if we get these injuries early enough while the meniscus is still in good enough condition, and the patient's otherwise well and they don't already have arthritis, and if they've got a stable knee, or someone we can give a stable knee by doing the appropriate ligament stabilization, then these are ones that will often do well with the repair. There are certain times where it's been either too long, or just the type of tear, or the meniscus is too damaged, where we do have to still debride that part of the meniscus, and that's sometimes a reasonable option in patients that are either a bit older, already have arthritis, or have a tear that's not suitable. So I guess the practical sort of type of, I guess the practical information is these the tears that need early referral are the ones that we're thinking about early repair, either to stop locking or catching symptoms early, or to have the best chance of a successful repair by the meniscus not getting too damaged, or that scenario I mentioned with trying to prevent future arthritis. So the main ones would be a displaced tear like that bucket handle tear when you've got a complete tear of the root or a complete radial tear. And the other ones we'd want to see early is if the patient's got physical sort of blocking or locking symptoms, as in they can't extend their knee past 30 degrees, for example, and they, despite analgesia and trying to do so, they physically can't do that. It's not a great situation to leave for weeks and weeks or for months, because then it's harder for them to get that range of motion back. And also during that time, it's not a nice situation for a patient to be in. So I guess the flip side of that, the ones where there's usually a role for starting with non-operative management are more your degenerative meniscal tears. So the ones that don't fit in any of those above criteria, and then degenerative tears or small undisplaced tears that haven't flipped or aren't causing locking or mechanical symptoms. And then there's those tears that you might see as an incidental finding. For example, someone's had a twisting injury, they've got say for example, a medial ligament sprain, and then they've incidentally got a lateral meniscus tear that they've got no lateral knee pain. It's just something that's there and not causing them problems. So those incidental sort of tears, and those ones are best started with a physio program. And even the ones that are going to be having surgical management, they're still good to start on an early rehab, just to maintain even their swelling and pain and their range of motion as much as they can within the limits, so that when they do have surgical management, they're on the front foot and ready to recover better. In terms of, we thought the other sort of useful thing to consider when you are talking to patients about the options for meniscal injury and how they're managed is the shared decision making between us and also yourselves, and also most importantly the patient, about how we're going to treat their meniscus. So leaving it alone, non-operatively managing it, versus repairing it, versus that debridement. And there's a lot of factors that come into it, not just the nature of the tear. Big ones are the age of the patient, how long the meniscal tear has been there, the symptoms they're having, do they actually match up with with it being from that meniscal tear that we see on imaging. And then a really big part is the goals of that patient. So the difference between, say, a 16-year-old with a big displaced bucket handle tear, we're going to do absolutely everything to try and repair it and preserve their meniscus and their cartilage, versus, say, a 45-year-old who's given up all their sport with the same tear, who's a professional carpenter who is self-employed and can't afford to have time off work. You'd be guided by those things as far as the likelihood of going through a repair, because a repair certainly has a much longer recovery than a debridement as far as the restrictions that we put on people. So the recovery does depend a little bit on the type of tear and then hence how we repair it. So ones that are more like that bucket handle or a horizontal tear, where the meniscus has kind of been pushed inwards and we're repairing that tear bit back to the outside of the knee, the weight bearing through it actually pushes that repair sort of almost out laterally towards where it came from. So it's not such a big deal to have the patient weight bearing through it. In fact, it's probably in some ways is a good thing. So kind of a careful weight bearing from early on, but just being careful with deep flexion depending on where the tear is a common restriction. So having them in a brace to control the side to side movement if they need to, but locking them from 0 to 90 degrees for 6 weeks and walking in a brace, and then being careful for deep squatting, weight bearing till about 3 months. That'd be a reason. There's variation with different surgeons and different tears and different techniques, but that would be a reasonably common sort of expectation of a repair of those type of tears. So if someone say you had a tiler or someone working on the floor that can't afford to be off work for that time and doesn't want those restrictions, that would guide you to maybe consider if they were in that slightly older bracket, that you'd debride rather than repair. Then there's ones where we're even more restrictive with the post-operative regime, and these are things like your radial tears. And Todd, tell me if you disagree, but I think the radial tears and the root tears, where we are relying on restoring that hoop stress and stopping the meniscus from extruding, then we really need to keep them from putting any significant weight through it for at least 6 weeks, and then a sort of a gradual return after that until the meniscus is healed enough to take the weight. Because if we're going through all the effort of repairing it and putting the patient through all that risk and everything else having surgery, there's not much point doing it unless we're appropriately allowing it time to actually heal and to have the desired effect of trying to prevent knee arthritis. So typically 6 weeks at least of non-weight bearing, and then pretty light until 3 months again. So all things to factor in when you are talking to patients. It's really a patient-centered thing that needs to be shared decision with them. Does anyone have any questions or any comments or questions or things I'd like to tease out from that in meniscal injuries? We've probably got plenty of time, so if anyone wants to now, otherwise you can pop them in the chat and we can go through things at the end. Sorry.
What would be the most appropriate initial investigation if you suspect meniscal tear? Is it an ultrasound or?
It's MRI is the sort of the gold standard. It's obviously then it comes down to cost and accessibility of that. And so if that's a factor, then even just starting with a weight-bearing X-ray, so a plain weight-bearing X-ray, particularly in actually in any demographic, first of all, it's going to rule out fracture, or at least an obvious fracture. It might show you things that you weren't expecting, like some findings if they had an ACL rupture that can be sort of diagnostic just on a plain X-ray. And if it's a weight-bearing X-ray, it'll also show you, and usually in that slightly older demographic, if they've got any underlying arthritis. And then you can put that together with the clinical picture. If they don't have any significant locking or catching, but they've got pain in the joint line and you suspect a meniscal tear, it can be reasonable just to start them rehabbing it as the first line, see if they're improving, and then MRI is really the optimal diagnostic imaging. If they get to the point where things aren't resolving. Likewise, if they've got quite significant catching or a really locked knee, then you might push for an MRI and orthopedic surgical review earlier on if their knee's physically locked. And sometimes, in some cases, that even needs to sort of come through the emergency department if they're truly locked and they can't function and they need to get things happening faster.
Okay, that'll be non-weight bearing at this particular point in time.
Oh no, not necessarily, unless you suspect a significant fracture. All other things would encourage them to keep weight bearing and keep doing their range of motion. So there would be the non-weight bearing more comes from when we've done the repair, and so it's protecting the repair rather than protecting the tear. I think if they've had a significant tear that's caused extrusion, it won't heal regardless of weight bearing or non-weight bearing. So it's better to just get them going, see how they can rehab, and then the one I'll probably get to in terms of that is that commonly reported on that, because there's so many more MRI scans being done with all of the radiology providers. One of the common things that gets reported when we're looking at fractures is that sort of subchondral undisplaced trabecular fracture, which people see fracture and then tell people to non-weight bear, and then by the time they kind of come to us, they've been often off it for quite some weeks and haven't been doing the rehab. Whereas those fractures are more almost like a bony bruising, where it's a very stable pattern, and they're actually better off just continuing to walk and continuing to rehab and treat it more like a sprain or whatever other associated injury went along with it, which could commonly be a ligamentous injury like a collateral ligament or an ACL.
Okay.
So the one of the other common injuries as far as ligamentous, and it looked like you are having a specific talk on ACL injuries, which we'll probably go into more detail about a lot of this, but I was thinking, just trying to keep this targeted to the initial management and who and when to refer early. So first of all, how do people do it? A little bit like the picture here of that horrible looking position of Chris Judd's knee, the external rotation of the tibia and a fixed foot with a pivoting type mechanism. And you can actually sort of see in that picture how the tibias come forward anteriorly relative to the rest of his knee. So relative to the femur, which is that restraint that the ACL is doing. It's the anterior translation of the tibia and stopping rotation. So it's much more commonly a non-contact pivot type injury rather than someone having a direct blow to their knee, feeling that classic pop or giving way. And then a lot of the diagnosis is in the history. It's someone telling you that they've had that that sensation. Athletes are pretty in tune. They'll come in and say, "I'm pretty sure I've done my ACL." And then that rapid onset swelling, it usually means one of two things: either a significant intra-articular ligament injury like an ACL or PCL or bony avulsion, or a fracture. So those are the two things that tend to swell up really quickly. So you go from a normal knee to a knee with a big effusion over an hour or two. Whereas meniscal injuries, they don't tend to get that large effusion, certainly not immediately. They might swell up a little bit down the track, but they don't blow up huge like that blood and basically fat from the bone and blood pouring into the knee and swelling it right up. So big parts in the history, because the exam in an acute ACL anytime after about an hour or two is pretty difficult, because they've got a swollen, painful knee. You can't move it around much. Anterior draw and Lockman's testing, which is normally your go-to sort of test for an ACL, can be quite difficult just because they're so painful and they're guarding and their muscles are tensing up. So yeah, it comes back to history and that exam with swelling. Versus if you're seeing someone with a chronic ACL injury, that's where it's more those classic exam findings. So anterior draw, where you're pulling forward on the tibia at 90 degrees, and a Lockman's test where you're pulling forward on the tibia at 30 degrees, and then a pivot shift test, which is something that's you can do in the clinic, but it's a lot easier to do when the patient's under anesthetic, and it's one of the ones we sometimes do to look at their degree of instability while they're anesthetized. Right. So yeah, imaging, which we touched on a moment ago, the on plane X-ray, it can be useful in that you'll see an effusion. So on the lateral X-ray, you'll see an effusion, sometimes also a lipohemarthrosis. So seeing that extra layer of fat, so fluid and fat, when you're looking on the lateral X-ray, if there's an associated avulsion with it. Then what's shown in this X-ray here, that second fracture, so that fleck of bone just up the lateral aspect at the top of the tibia, which is kind of pathognomonic for an ACL injury. It doesn't necessarily tell you if it's an acute or chronic ACL injury as such, but if it fits in with their history, you've already pretty much got the diagnosis on a plain film X-ray of ACL rupture. On X-rays, sometimes on the lateral, you might see the impaction of where the tibia has come right forward and actually impacted into the front of the femur, that part of the femur called the sulcus terminalis. There can be a dent at the femur. And then on X-ray, if it's a younger patient, so a skeletally immature patient, like a teenager that's hurt their knee, you might see an avulsion of the tibial spine, which is the pediatric equivalent of an ACL rupture. So that's where X-rays, we don't want to lose the art of plain film X-ray with all the MRIs being done, and it certainly can offer some information, especially if it's not clear and you're still wanting to rule out a fracture. It's never a great thing to go straight to wait to get an MRI and then find they had an obvious displaced tibial plateau fracture diagnosed that could have been showing up on a plain X-ray. As far as MRI, it shows all those same things. Plus, we directly look at the ACL. So on the sagittal images, we look at the ACL crossing from front to back, from the tibia to the femur, and the PCL crossing the opposite. So you're looking at both of those things. It'll also show us everything. So it'll show us all the meniscal, if there's any other meniscal injuries, any other ligamentous injury, and Todd's going to talk about sort of the multi-ligamentous injuries and other combinations of injuries you can have with an ACL. And so I think this is hopefully the bit that will be some use as far as practicality. So early management, which applies to everyone with and not just an ACL, but an acute knee injury or any acute injury. So RICE, so your rest, ice, compression, elevation. As I mentioned, generally most patients, you can let them keep weight bearing. So unless there was a significant fracture or anything else we were concerned about, they can continue weight bearing and just use a gait aid as needed, which in these patients will most likely be crutches. And then start early range of motion and gentle strengthening as tolerated, and start physiotherapy. And so there's not many situations where that doesn't apply for an acute knee injury. They want that head start no matter what the ultimate diagnosis is. And then I've sort of touched on the meniscal injuries that need acute referral, which are those displaced tears, so displaced bucket handles, root tears. If they've got an associated fracture, and that probably excludes those ones I mentioned with that sort of MRI diagnosed more bony bruising subchondral fracture. But if they've got a fracture that's either displaced or there's uncertainty as to whether it's displaced enough to warrant fixation, it's nice to sort of see or discuss them early just to make sure we've got the right imaging, and whether that might be a CT scan to look at the bony detail, but probably a good time to just discuss and plan that anyway. Other ones are, so if it's a pediatric patient with that tibial spine avulsion of the ACL, they're good to be seen early because they often either need close follow-up to make sure that the fracture remains minimally displaced, or in the cases of where it is displaced, they often need surgical repair early. And that's a different kettle of fish to ACL rupture of the ligament, where that tends to, in most cases, if it's being surgically managed, benefit from a reconstruction using a tendon or some other tissue. In these ones, because the ligament's grossly intact and it's a bony avulsion, we can repair the bit of bone back down to the tibia where it's come from, and that's why it's better managed in the early setting, so that can still be done. Multi-ligament injury, which is what Todd will cover, and then potentially in those high-level athletes that are sort of really planning that want to plan early for their return to whatever sport it might be that they're wanting to get back to, chatting to them early about, timing of ACL reconstruction rather than having them wait is probably useful. And then the algorithm after that, acute management, is certainly ACLs in the game. It sounds like you'll have a full talk on this, so I'll gloss over it pretty quickly, but there's certainly a large proportion of people with ACL rupture we can manage without a reconstruction, and those are the people that are either past their sort of competitive sporting age, so a lesser demand than that, going back to pivoting sports, or have decided this is the point where they want to stop that. If they don't have instability symptoms, and some patients just strongly prefer to, try everything for non-operative management, or if they've got particular commitments that they need to be doing that doesn't allow them to have time off for surgery and the recovery, then at least initially they may want to trial non-operative. And also, ideally without a significant meniscal injury, something that in its own right would require surgery. And especially when we're thinking about meniscal repair, it's sometimes a bit of a catch-22 because we don't tend to like to repair a meniscus in an unstable knee. And so sometimes it's a little bit all or nothing. If someone has a bucket handle tear of their meniscus and an ACL rupture, and they would say, mid-40s, and they wouldn't have otherwise been having their ACL reconstructed, we have to then make a decision with them as to whether we then just debride the meniscus or leave it alone, or if we are doing the repair, then they sort of have to embark on that whole journey of that plus an ACL reconstruction, which is much, much bigger. Versus those with that that'd be sort of undergoing ACL reconstruction. So the younger patients wanting to return to pivoting sports, or those that have tried rehab and whatever their goals are. So whether that's just their activities of daily living, or whether that's a return to sport or kicking the football with their kids or whatever it might be, if the knee keeps giving way despite them doing a significant amount of rehab and strengthening and proprioception and physiotherapy, and they can't do those things, then sometimes we then do a ACL reconstruction for those patients. And most commonly in Australia, we're using autograft, so the patient's own tissue, either a hamstring or quads are probably the most common at the moment. Patella tendon also still gets used a fair bit. That was more common in the past, but certainly all three of those are good options. And then less so in Australia, certainly for primary ACLs, is things like allograft, so donor tissue, or synthetic. Synthetic went through a big phase whenever it was 10 or 15 years ago, and synthetic alone didn't tend to do very well. So we're back to sort of basically taking tissue from the patient, and so we have to weigh up the donor site morbidity and everything else with that as well. And then the relatively long recovery, so that a normal sort of ACL, they'll be walking, weight bearing is tolerated from the start, starting early rehab, but for the graft to actually get strong and integrate, it's quite some months, and really till about it's weakest at about 4 to 6 months. And so it's really about 7 to 9 months before they can even consider getting back to any significant level of sport. So for most people, that's a good sort of full season or 12 months before they're really back to their sports. So does anyone want to jump in and ask or add anything on ACLs based on that? Or otherwise we can save it and carry on and do it all at the end. So looking at fractures around the knee, and again, this is a pretty big topic on its own. So probably more trying to cover the things you might likely see through a primary care GP setting, because a lot of them, the higher trauma stuff will hopefully come directly to emergency, but obviously not always. So tibial plateau, the general principles are if they're displaced, and there's different cutoffs, and it depends a bit on the patient and their underlying risk factors, but anything between about 3 to 5 millimeters of step in the cartilage, they'll have a increased risk of arthritis, or anything where there's malalignment of the knee as a result, they'll have likely long-term issues. So in those patients, we tend to recommend surgical fixation, but there are a lot of relatively undisplaced tibial plateau fractures that can be managed non-operatively. And then that next line is just talking about those fractures that I mentioned before, like in that picture where it's more just like some bony bruising type signal reported as a subchondral fracture. But they can be treated, with early weight bearing rehab and non-operatively. So that's probably, I think that's a really good thing, because it's so common that they're reported on MRIs. It's probably a good thing to just keep emphasizing, is that fracture doesn't necessarily mean fracture. And so if you sort of end up either looking at the image or teasing out the wording, and it's something completely undisplaced like that's going to be stable, then it's treated quite differently to a normal fracture. Similarly with distal femur fractures, depending on if they're displaced or undisplaced, as to a lot of them will require surgical management or at least extended periods of non-weight bearing, but you can get a similar bony bruising type pattern, which again is more just early rehab. Patellar fractures, it all depends on, I guess, two things: how much the fracture has displaced, and then if they've got an intact extensor mechanism, which is a pretty hard thing to determine. If it's undisplaced, the chances are that they can't straight leg raise because of pain rather than anything else. So it probably more comes down to, is the fracture displaced, and then what are the patient's pre-existing risk factors to have surgery, and what are their goals and their level of function, and as to whether we can treat them non-operatively or operatively. And then other fractures, collateral ligament avulsions. So if it was a medial ligament, for example, that takes a little bit of bone with it, usually off its proximal insertion on the femur. Sometimes these can be considered for early surgical repair if it's a sort of a complete avulsion with displacement in an otherwise well patient, or those ones I mentioned of the tibial spine and pediatric patients. So that's a very brief summary of fractures, and it's something we could do a whole talk on. So if anyone wants to sort of jump in with any question or comments now, Todd, then hopefully it looks like Todd's got some much more exciting and interactive videos and things to liven things up for the second half of the talk. But if there's any of those topics you want to chat about first, and then we can carry on.
Hey, Nick, I have a question. Can you hear me all right?
Yeah.
Great. So when a patient reports locking, but they can move past the point of locking, would you still consider that as locking? Is that wording still all right?
Yeah, no, it's a good question, because so often patients say, oh, my knee's locked, I can't get that. But then, either when they're distracted or appropriate analgesia, or they're warmed up, or likewise when we give them an anesthetic and you go and the knee just bends up straight away. It's amazing how common that happens. It's just that they feel the pain of whatever's catching and it stops them. And then, so it's a very good question. I think true locking is where they like physically cannot get past that point, or like a locked knee, that is. They can have a locking symptoms or locking sensation where they feel it locking, but they can move past it. So I guess it's kind of teasing out a truly locked knee where it's physically blocked to movement, which is the sort of more, I guess, relative emergent thing to manage, versus symptoms of locking and catching, which is more a patient reported thing. And the locking and catching is more something that can be treated still with with rehabilitation, with physio, and then if they have those persistent symptoms is where you treat it surgically. Whereas a physically locked knee where it won't go past that no matter what you do, and even when they're asleep, technically that you lift up their knee and it won't go, say, extend past 30 degrees. That's more the one where they're not going to make gains, often won't make gains without surgery. And that can come and go. Like, for example, if they've got a tear that displaces into a certain point, it locks and they physically can't move it, then they can jiggle it around, get in a certain position, it might unlock. But if it's frequently locking where they can't move it like that, and that's happening a lot, you would more treat it like that sort of acutely locked knee. Yeah.
Perfect, thank you.
If that makes sense. Cool. Well, we can, if it works, we can hand over to Todd for some much more exciting PowerPoint, just seeing his one go through.
Good one. Okay, so I think you've just got to unshare yours,
Yeah,
Nick.
there we go. Sorry.
No, go on, thanks. All right, is that working better? Is that working okay? Sorry, guys.
Yep,
Yep.
all good.
Yeah, okay, cool. So yeah, again, Nick's already done the introductions, but thanks for having us tonight. This is sort of a quick background of me. We'll sort of skip through it, but I've been in Geelong now for nearly 3 years, and sort of worked around in a few places. These are my kids. I put them in just because they're cute and just as a sort of liven things up a little bit. But these are the things that I'm going to talk about. So I'm going to talk about patella dislocations. Like Nick, try and sort of talk about, the early management and what tests we need to do and hopefully when, so that more sort of practical things. And then just sort of give a rather than sort of be too technical, sort of an overview of what we do in surgery and what options patients have. Then we'll talk about the non-ACL ligament injuries, so the MCL, the LCL, the PCL, and then the combination of those injuries where you get that multi-ligament injury. I do have some videos in this that hopefully no one's sort of too squeamish, but there's fair warning. So start off, we're going to talk about patella dislocation. So you can see this is sort of fairly common thing that we see in footy. And you can see it's pretty painful when it's out. You can see the look on his face there as it goes back in. It's pretty, it's instant relief. So patella dislocations are pretty common. I was amazed that it was only sort of 2 to 3% when I was looking at the literature. I think obviously seeing a slanted population in my practice, but I would have thought it was a bit higher than that, but still common. Typically seeing it in that younger age group, the teens and the 20s, that more flexible, stretchy, stupid, for lack of a better word, population that are probably doing things that they shouldn't be doing. And so that sort of fits with the risk factors that we're looking for people that have patella dislocation. So those that are ligamentously lax, if you've had a previous dislocation event, you're more likely to have a recurrent event. And those ones that do go on to have recurrent problems are, again, the younger ages. As you get older, you naturally get stiffer, and that's protective for dislocations pretty much in any joint, but certainly in the patellofemoral joint. Those that have patella alta, which is the long patella tendon, so it allows the patella naturally, it's just a variation of normal, but it allows the patella to sit much higher relative to the trochlear groove. And so it means that you don't have that protective bony barrier of the knee when it's bent. Or not, it takes longer for it to engage into the trochlear, so it's more likely to translate. And then the final is trochlear dysplasia. And so this is a narrow or a shallow trochlear groove. And so that can be sort of mild, moderate, severe, where there's a whole bunch of ways that people classify it. But in essence, you can have a shallow groove, you can have a flat groove, or even a domed groove. And you can appreciate how difficult it is to keep a joint in place if you've got a domed patella sitting on a domed trochlear. They rattle in and out all the time. And then ultimately we're sort of looking at muscle imbalances. So as Nick was sort of saying, you can see that the majority of things focus on physiotherapy as the first port of call for treatment. And that's really to work on the quads muscles, or all muscle groups together, but particularly we talk about the VMO, the vastus medialis obliquus. That's the muscle that is pulling the patella more medially. These always dislocate laterally. And you'll see that with any injury or any sort of effusion in the knee, that quads will just melt overnight. It's really quite dramatic how quickly that happens. So you end up with an imbalance where the medializing structures get weak, and then the things that are pulling it more laterally and predisposing to that dislocation become tight, and they get set up in quite a vicious cycle. The mechanism of injury, again, it's that sort of, there's two main mechanisms here. That non-contact twisting injury where the foot's planted and then they rotate and that allows it to pop in and out, or that more direct blow. So you see it in the footballers or the basketball players where they have knee-on-knee contact and it just pushes that kneecap out. Often these do spontaneously reduce. As you can see, this video here, sorry, it's not still playing, but this video of Darren Creswell, this is not how to put a kneecap back in. He sort of quite famously did this mid-game and kept playing, but that is almost guaranteed to cause an injury to his quadriceps. If he'd straightened his knee, it would have been a lot easier. And so these are the things that we're looking at. So patients will often come in, if it's a primary dislocation, it's often quite dramatic and they'll sort of know that there's been a problem, but you'll get that more subtle subluxation or dislocation event, particularly in the recurrent dislocators, where they'll complain of a pop or a clunk, or they'll feel that the knee just gives way on them at unpredictable times. And that can be when they're sort of changing directions, in the extremes, when they're just walking around, not even sort of necessarily playing a pivoting sport. Once they start getting pain in the front of the knee or under the kneecap, that's a real concern. That's where you're worried that there's significant chondral damage here and they're developing that secondary arthritis. From a physical examination point of view, there's a lot to be seen here. So for some people, you'll see that they have a subluxated or a chronically dislocated kneecap. In the acute setting, again, you'll see that big, large, tense effusion in the knee. They'll often be tender along that medial pole of the patella. Because these do always go laterally, you tear the structures on the medial side of the knee, so particularly that medial patellofemoral ligament. And so again, in the acutes, these can be really quite sore. The recurrent dislocators, that can be less significant. This is showing what we call a J tracking sign. So you can see when this guy starts with his knee flexed, his kneecap's engaged in the trochlear groove and it sits centered. But as he extends his knee, you can see that line of pull of the quadriceps is to pull the whole thing laterally. And as the patella disengages from the trochlear groove, it allows it to kick over. And so that's what we call J tracking. And that's a sign that someone is got really actually quite bad patella tracking. The other thing we look at is what we call the apprehension sign. And so that's just simply putting your thumb or your index finger on the medial side of the patella and trying to push it out. And you'll see the patient will stop you and say, please, don't, it sort of recreates that sensation that they become accustomed to, that the knee's going to go out, and they don't like that. So in terms of investigations, there's a lot that can be seen just from the plain films. So you can see this, the AP and then the skyline view there showing a frankly dislocated patella. The other thing that we look at is the patella height, and that's what I was talking about before that patella alter. There's a bunch of ways that we sort of argue about what the most accurate way of measuring these is, but essentially you're looking at how long the patella tendon is, so that arrow on the inferior side there, and then as a way of relating it to natural variation in patient size and shape is a ratio compared to the height of the patella. And so as that bottom arrow increases, you can imagine that allows the patella to sit higher, and so it engages the trochlear groove later in flexion, which allows it to have more play and more likely to dislocate. The MRIs, they can show us more, sequelae of a dislocation as opposed to giving us the diagnosis. You can see in this picture on the left, there's a huge amount, all of that white fluid that's sitting in the knee there. That's a really quite a large effusion in the knee. And then chondral loose bodies that are pulled in the gutter on the lateral side there. Often these have come from the medial facet of the patella or the lateral femoral condyle, and that's when it's kicked out laterally, as it reduces back in, it'll shear off the medial facet. So it's usually where those loose bodies have come from. And on the right photo, you can see it's just sort of showing some of the structures that we look at. That patella is not centered in the groove. It's sitting tilted laterally. They're showing an MPFL intact in that picture. Likely that's more strain, but that's the structure that we're looking for. And you can see that's that check rein to keep the patella more centered or pulling it more medial, as opposed to, we're always fighting the quadriceps that wants to pull it out laterally. And then you can see in that dotted line showing that this is an abnormal trochlea, in that it's quite a flat, as opposed to a deepened groove like you can see in the other picture. And then finally, CT scans. This is really just used for surgical planning for us. And so it's a bit of a complex overlay, but it's looking at the relationship of the depth of the trochlear groove on the femur to the tibial tuberosity, being the attachment of the patella, and then just measuring how wide they are. So that's a parameter that can predispose to lateral cracking of the patella, and something that we can fix during surgery if needed. So getting back to the first aid treatment, the first thing to do is reduction. And you can see this video showing a much more gentle way than what we saw Darren Creswell doing on the football field. This is much less likely to cause an injury. And you can see it's just coaxing this patient to slowly relax their knee, which it can often be harder, easier said than done. That muscle goes into spasm, but just slowly getting them to straighten it out will allow the patella to kick back over. And then, as Nick said, it's rest ice compression elevation. Often these patients are given splints and crutches, particularly once they've come to the emergency department. They might sometimes need some sedation to get that reduction. The splint's not the worst thing, but we definitely try and tell people to try and get rid of it as soon as possible. Exactly like Nick was saying, that deconditioning sets in really quite quickly for these. And we're trying to strengthen particularly that medial muscle, as soon as possible. So I think I'm not against it, for the first 2 or 3 days, I guess, as pain relief, but getting them moving early is really important to get rid of the swelling and to regain that muscle. I think historically the teaching has been to split them and non-weight bear them for even sort of 2 or 3 weeks before starting physio. And I think at that stage it does more harm than good. And so physio, particularly for the primary dislocators, it really is the mainstay of treatment, or the gold standard. And so we sort of encourage them to get engaged in that process early. It's the best way to recover the muscle and also to shift that swelling. A lot of physios will do taping. There's pros and cons in taping, but I think it's one of those things that doesn't really do any harm. So whether you believe in it or not, it's often an option for patients, and I can't see a downside to it. The ones that we think probably to refer, the red flags that we look for, is if in those initial x-rays that you get seeing a fracture. So particularly on the medial side of the patella, you'll often see a bony avulsion of the MPFL. We like to see those early because that's something potentially that we could operate on early. Or other times you can see large chondral fractures too if they've been sheared off. The more difficult ones are those that sort of fail to improve, or that have that persistent swelling, or that just can't weight bear. That's usually a bit of a warning sign that there's something else going on, particularly thinking about chondral injuries. Have they sheared off the cartilage on the patella? Then we would like to see those a lot earlier. And that fits into that catching, locking sensations again. Is there a loose body in the knee? And then ultimately those that go on to having recurrent dislocations, where it's affecting quality of life, their ability to participate in sport, then those are the ones that we like to see as well. So the surgery, often we're looking at trying to correct whatever the underlying pathology is. So if it's a cartilage injury, it might be trying to put that cartilage back on, sometimes even more commonly, just removing that piece. This picture in the top left here is what we call an MPFL reconstruction. So it's using one of the hamstring tendons to rebuild that check rein and attaching it to the medial side to try and prevent that lateral translation of the patella. And then for the more unstable, or those that have either the high patella tendon or even a lateralized tuberosity insertion, then we do something called a tibial tubercle osteotomy. And so that's taking that whole tibial tubercle off the tibia itself and using it to distalize and sometimes even medialize the insertion. So trying to change the line of pull for the kneecap and getting it to engage that trochlea earlier in their range of motion, because that's the best check rein to the lateralization of the patella. And then finally, something called a trochleoplasty. So this is not a common operation. I saw a few of these when I was in Bristol. They were sort of one of the main centres in the UK that did them. I think in Melbourne, there's a couple of people at the Children's Hospital doing them. That's the age group that probably respond best to them. But the idea here is that you're actually undermining the whole anterior flange of the cartilage on the femoral condyle and digging a well of bone out from behind it and then pushing it down so that you're taking it from that flat picture in A into the groove picture in B. So it's big stake surgery. So often there's other things that we can do to not need to go that far, but some patients certainly do need it. Most often we're doing a combination of a few of these sorts of operations. So in summary, patella dislocations, they really are common. The first line of treatment is really getting that movement back, restoring the quadriceps strength. And then really the advanced imaging, things like MRIs, are really only needed if some of those red flags are present. So does anyone have any questions on that so far? Cool. Okay. So then talking about knee ligament injuries, so the non-ACL ligament injuries, there's the four main ligaments in the knee, the ACL, the PCL, the MCL, and the LCL. We're generally seeing two populations of these, the higher velocities, like our gymnasts here, where there's an extreme force across the knee. And then unfortunately, the more common that we're seeing now is these what they call the ultra low velocity in the morbidly obese patients. So those patients that have high BMIs, that have simple falls, and it's just a torque on the knee that unfortunately just ruins their knees, and they're really difficult to treat. So if we start first with PCL injuries, these are sort of reasonably common. There's a few different mechanisms that they talk about. The classic that we'd see in Australia most commonly would be that dashboard injury. So a direct force to the tibia forcing it backwards, like a dashboard in a car accident. In the American literature, they talk a lot about this idea of this hyperflexion with a plantar flexed foot, particularly in their NFL players and in soccer players. Most commonly, what we do worry about with these is that you can see them with combination injuries. So it's rare to get a significant PCL injury in isolation. The amount of force that's required to injure PCL is tremendous, and that often causes other injuries. And so we're often seeing them in combinations. The history can be hard. As I say, it's often not quite as dramatic or as the ACL. And so we have to have a high index of suspicion based on the mechanism. Patients will sometimes present with knee pain around the back of their knee, but even the instability that you get from a PCL injury can often be really quite subtle. The way we look for it on physical exam is you're looking for a posterior sag. That's what this picture sort of starts with showing. If you look at when he relaxes there, the tibia, you can see, just translates a long way backwards, and the femoral condyle becomes really quite prominent. The next thing you're looking for, you can do a posterior draw, like the opposite of what we do in an ACL test, where we do an anterior draw. And then again, this video is showing what we call a quads active. So has his foot anchored and he's contracting his quadriceps, and you can see that's dragging that tibia back to what would be considered a normal station. And so we often see that people might do a normal knee examination and misdiagnose, a PCL injury as an ACL injury because they're getting that Lockman's or that anterior draw, and it's because they're starting at an abnormal station to start with. These can be hard to see on X-rays. Often you see that the normal AP lateral X-rays that we get don't appreciate that translation, and so we need to do what we call stress views. And so these pictures at the top is comparing a right to a left knee, where they're actually they have a force applied to the front of the tibia, pushing it backwards. And you can see the two lines that I've drawn there is just showing the increased translation on the right knee here compared to the left knee, showing that there's laxity in that ligament, or this modified axial view where it's letting gravity allow the tibia to sag back. And again, looking at the overlap of the tibia in the back here compared to the femoral condyles, and seeing the difference on the side-to-side difference from the injured side to the normal side to see what's normal. MRI is often used, but it can be misleading, particularly in a chronic PCL injury. So this on the left, this is marked in blue there. That's what a normal PCL would look like. And then you can see on the right-hand side there, a torn PCL where you've got the distal stump is present and then it just sort of fades away after that. So that would be a mid-substance PCL tear. The treatment for these, often when they're isolated injuries, as I said, that's fairly rare, but they're actually reasonably well tolerated. And it's really not common to need to do a repair or reconstruction of an isolated PCL. For these, we can rehab with the standard protocol, RICE. We'd say protected weight bear whilst they're symptomatic, so until that swelling settles down, getting them into physio again, and usually back to sport fairly quickly. For the more high-grade injuries or in combination with other ligament injuries, then we're typically being a bit more aggressive and looking to either repair or reconstruct. It's a surgery that, fortunately, we don't have to do commonly, but it's pretty stressful when we do it, because you can see that in trying to do all of the work to get access to where the PCL starts at the back of the tibia there, you're drilling towards a pretty big pipe at the back there that is just on the other side of the capsule. So fortunately not something we have to do often. In terms of the collateral ligaments, I've sort of grouped them together because there's some similarities and some important differences too to sort of look at with those. But the medial collateral ligament is the most commonly injured. Often we don't even sort of realise it. It's the most common injured with an ACL. So as Nick said, when you're looking at the ACL tears, often you do see the MCL tears to go with it. These are more commonly a direct blow to the lateral side of the knee, and you can imagine that just hinges open that medial side, puts a real stretch on it. These fortunately have a fantastic healing potential, particularly those tendons that rupture like this one here at the more proximal origin. These actually, with bracing, can stick down quite nicely, and it's not common, fortunately, to need to repair or reconstruct them. When we talk about the lateral side, these are really rare in isolation, only sort of 2%. These really are more commonly seen with either a posterior lateral corner injury or a PCL injury. And again, it's the direct blow this time to the medial side of the knee, and again, hinging open that lateral side. And you can imagine that stretch that you have where the lateral side is distracted open puts a lot of strain on the common perineal nerve as it runs around the back of the knee and around the neck of the fibula here. And so these have a high rate of neurovascular injury. These don't heal well. So we're often being a lot more aggressive with repairing or reconstructing these because they don't have that inherent healing potential like the MCL does. There's a whole bunch of ways to classify these. Often the clinical exam can be quite difficult. They talk about sort of grading the side-to-side difference, and usually what is most helpful is, again, these stress x-rays. So this is x-rays I've taken. This is my hand in a lead glove of sort of putting a force and trying to open up that knee. And you can see the side-to-side difference of this medial compartment compared to this medial compartment with that MCL gone. And so often we're using these to better get that grading because it can be hard to see on clinical examination alone. So the treatment for these, it's hard to give a real sort of one size fits all. We do like to, because there's a lot of subtleties and associated injuries with these, we probably do like to see these a lot earlier than, say, the ACLs, where you can give them a bit of a run and see how they go with physio. But a rough rule of thumb is, a proximal MCL tear heals really well. We tend to protect it in a hinge knee brace for 6 weeks, as is if you get that rare isolated LCL. But more commonly, we're seeing these ligaments in combination. And so they're probably ones that we do like to see earlier while there's options for repair or reconstruct or to integrate the appropriate bracing while you've got that therapeutic window still open. So in summary, knee ligament, they're really common. The clinical exam is key. As Nick said, we're getting a lot more MRIs are more readily available these days, and they'll pick up a lot of subtle injuries, but it can be hard to then work out how significant they are, and that's where the clinical exam can be really helpful with that. So I hope with that I sort of haven't given you too many toys there to play with and sort of overloaded it with too much, but I sort of tried to give, I guess, the rough, the headlines of what we look for. Does anyone have any questions?
No questions? Feel free to type them in the chat. We do have a little bit of time if you've got any questions, or take yourself off mute and ask anything.
Question.
Go ahead.
Thank you for the content so far. It's been just wondering about the posterior lateral corner kind of pain versus, I understand it has to be pretty catastrophic injury for us to see a true sort of posterior lateral corner where it's a multiple ligament injury. But what in a subjective would kind of make you suspicious about, is this like some kind of chronic instability thing, or like in case not to miss one, I guess?
So it's a good question. So the mechanism to have a true post-lateral corner injury is really quite high. And so usually they're presenting acutely because it is a very painful injury. And so then you're seeing that lateral sided laxity, often with the posterior sag as well. There's a clinical examination called the dial test that we do to really look at that. And so you're testing where the capsule and things are as well. And all of those tests will be positive in the acute and the chronic setting. And so that's sort of how we would tease that out. Often the MRI is much less useful in that setting. It's good in the acute injury, less so in the chronic, and that's where I most typically is using the stress views to really try and test, the stress X-rays to see what those ligaments are doing in a more dynamic setting.
Okay, thank you.
There's a couple in the chat there. So the best clinical test for meniscal tears, I think the most specific one to diagnose it is history, and then pain on the medial, say for example a medial meniscal tear, medial joint line pain with tenderness that's reproducible right in the medial joint line, and then you can combine that finding with pain that worsens right on that spot with, say, a McMurray's test, which is that holding the foot, internally rotating the tibia, putting a varus stress so that those things compress the meniscus, and then taking it through like a circumduction position. So the McMurray's test on its own is not particularly diagnostic because that can create pain in anyone's knee, but it's matching it up with having your thumb on their medial joint line and checking that it reproduces pain right on that spot and clarifying that. Or if it gives any locking as you do that, that's again reproducible under your thumb. So if someone's got patellofemoral pain, they'll no doubt have pain, and sometimes catching with a McMurray's test. So it's that combination of palpation with that. There's lots of other sort of grind tests and weight bearing type sort of single leg rotation type tests, all of which are probably as good as they're as useful as they are sort of I guess the skill and the actual how well the technique is done in terms of carrying them out. But yeah, for me, in terms of a reliable, quick way, it's combining palpation with McMurray's, but it's also what you get used to as well.
Could I jump in too? I reckon the history is key on that too.
Yeah.
That what we sort of roughly group as those mechanical symptoms. So if they present, say, like this clicking and this catching sensation, as that meniscus sort of displaces or folds on itself and it jams like a rock in a hinge, often patients will tell you, they say, oh, I feel it, and it comes and it goes. It's not there all the time. Sometimes their knee will blow up after they've had that sensation. They're getting that recurrent effusion sort of episode, as opposed to, say, an arthritic knee where that pain's there all the time. Might get worse when they walk on it, but it rarely goes away, and particularly it gets worse at nighttime. Whereas that meniscus, a significant meniscus injury, it's a functional problem, and that I think those mechanical symptoms are really key on the history.
And there's a question about thoughts on cross bracing. Todd just presented us a journal club on this, so he's pretty up to date with it. But do you want to comment on?
Yeah, it's an interesting study. Historically, we were always taught that there was no healing potential in the ACL, and this sort of goes in flight of that. It's a local study. It was done in Sydney, and it's got some really interesting results. From a scientific point of view, there's some real methodological flaws in the way that it was done and the way that some parts have been reported. And so I think it's a work in progress, and I suspect there's going to be a lot more data on it coming out. that I think there's probably something there, but I don't know that we've quite nuanced yet who's the most appropriate for it and who's the best to have that to go down that pathway. But I mean, I've seen a few patients with it lately that have come from particularly the sports physicians that are really keen on it. And I think you lose very little by trying it initially. You know, as Nick said, if you commit to an ACL reconstruction, it's 12 months of rehab, which is a lot. And so you do see those patients where they say, look, you know, you can try this bracing protocol. And it's certainly a quicker recovery than if they have surgery. It's pretty cumbersome. The first 8 weeks, they're actually locked at 90 degrees at all times. They have to sleep in the brace. They're on crutches. So it is, in its own right, it is a big commitment. So I think the jury's out on it. We need more data, but it's certainly interesting. And we're seeing a lot more of it in the community.
Yes, Todd. And then the question from Ben about do meniscal tears heal with good management, or do they rely on sutures for debriding? I think a lot of meniscal tears do heal. So it depends on where the tear is. So if it's in that outer 1/3 of the meniscus, which has a pretty good blood supply, they can heal quite well as long as they're in a position where the edges are sitting opposed and aren't displaced. So there's probably a lot of meniscal injuries we never know about because no one had no one had imaging for them when they injured it, and they do get better on their own. And we sort of see the ones that don't heal either on imaging or arthroscopy. But yeah, it's like when we do a repair of a meniscus, we have a much higher success in those ones that are more towards the periphery of the meniscus because it's the outer part has that blood supply. So similar ones that would heal on their own. And even if they don't necessarily totally heal, say on an MRI, if they sit in an undisplaced position and hence aren't unstable or causing movement of those fragments and then tend to not be painful and tend to not cause any mechanical type symptoms, then it probably doesn't matter if you still see a small tear, and that might be why a lot of them are asymptomatic. And then from Janet about posterior lateral joint line pain after a pivot mechanism considered ACL until proven otherwise. I think the biggest thing after a pivot mechanism is that immediate history, so that patient describing the pop, the immediate effusion. And so if you're thinking more like that will probably supersede any posterior lateral joint line pain. If you're thinking more a subacute presentation and they've got pain around the posterior lateral joint, my thoughts would be that if they've had that pivot mechanism and you're worried about an ACL and they had pain around posterior laterally, you'd be thinking, could they also have a posterior lateral corner injury associated with it? Because ACL is typically more sort of that deep central pain. Would you agree with that, Todd? Or
yeah, absolutely. Or even an associated meniscal tear. Often when you get that hyperextension loaded thing mechanism that causes an ACL injury, you can crush down on the lateral meniscus. So I think that's probably partly where that comes from as well.
Yeah.
The ACL injury itself typically isn't painful. They actually recover from that quite quickly. It's the associated injuries that's usually painful.
Thank you. I'll just take this opportunity, if there's no more questions, to thank everyone for attending and for the interaction with our two presenters. Thank you, Nick and Todd. Great presentations, really well received. Thank you so much for taking the time to speak to our GPs. If GPs have got any more topics on orthopaedics they'd like, we do regular orthopaedic updates. We have a couple of face-to-face in all our regions coming up the end of July, August with orthopaedic surgeons. I think Geelong Orthopaedics are doing the presentation in Geelong, so look out for those. And I'll just end the webinar for all now, and thank you all again. Bye, everyone.
Thanks for having us, guys. Cheers.
Thanks, guys.